All right, everybody. So we're going to get started. Just a couple people filtering in. Thank you all so much for taking the time to join us for a second round of Dr. Awuor's Educational Happy Hour. My name is Vic Sharma, and I will be assisting Dr. Awuor in hosting this wonderful event. Now, if you all don't mind, please mute your mics and turn off any video you guys have just to save all the bandwidth. You can do this on the bottom left of your screen. Also, if you have any questions during the lecture, please write them in the messaging box utilizing the chat function. Additionally, Dr. Awuor has allotted some time during the presentation for some Q&A. He just asks that you introduce yourself when you do want to ask a question so the entire audience knows who you are. Now, for those of you who have not worked with him, Dr. Awuor is not only a phenomenal neurosurgeon operating at a level 1 trauma center, but he's also one of the best teachers that I've worked with inside and outside the OR. I couldn't be more excited for part 2 of his complex cervical series, and I'm sure you are too. Dr. Awuor, thank you so much for your time. We are all ready to go whenever you are.
All right, can everyone hear me?
Crystal.
All right, so I'd like to thank everyone for taking the time to join us for the principles and techniques of the management of upper cervical trauma. Again, this is a continuation of our last lecture. So I will go over, I'll start off by going over some of the old material just for a review, and then we'll go over the new information. And I do encourage some dialogue. If you would, please do participate. I know I didn't get much chiming in from our OSU colleagues last time, so hopefully we can get you to chime in a little more this time. So don't hesitate to ask questions. The goal is to make this as interactive as possible, considering our limitations, but we want to make this as interactive as possible. Without further ado, let's go ahead and get started. Again, I'm a neurosurgeon at Ohio Health Grant Medical Center in Columbus, Ohio. We see a lot of upper cervical trauma, and hopefully I can share some of that experience with you, and hopefully you pick up some things that may change the way you practice, or at least give you something to think about. Now, the occipital cervical junction is the area from the occiput to the C2-3 disc. This place is very unique embryologically, anatomically, and biomechanically. There's complex bones, joints, and ligaments. The unique bones here are the atlas and the axis. Now, the atlas has these two lateral masses, and then you have the anterior and posterior arch that form this ring, and the axis is has this dens that extends perpendicularly from its body, and this dens serves as the pivot point for the atlas. Understanding this biomechanics is very important. The most important ligament that's providing stability to this area is the transverse ligament. This transverse ligament right here is the most important ligament in this region, and it's going to be very important in your surgical decision-making as it is the main stabilizer of this particular area. The most important vessel that we need to know here and really understand its course is the vertebral artery, as it goes in through the transverse foramen, loops around the arch of C1, then goes through the dura, and then intracranially. So it's important to understand the course of the vertebral artery. In fact, we get a CT angiogram or MRA, some vascular surgery, some vascular study of some sort before really doing surgery in this area, because it can save you a lot of trouble to really make sure you study the course of that artery prior to any kind of surgery in this area. Again, I'm going. A lot of this first part is from my previous lecture, so I'm going to skip some of it. The kinds of injuries in this area, we're going to have occipital condyle fractures. We're going to have Atlanto-Occipital dislocations, atlas fractures, rotatory atlanto-axial dislocations, odontoid fractures, Hangman's fractures, and combined C1, C2 fractures. I won't go too much into the combined C1, C2 fractures today. Maybe we'll have a future session where we'll go through the combined fractures. But typically, as a general rule, with combined C1, C2 fractures, you usually treat those fractures that, as you would treat the C2. The C2 typically determines how you're going to treat a combined C1, C2 fracture. So however you would treat the C2 fracture, usually that's going to address both what's happening at C1 and what's happening at C2. Here's a case we discussed previously of a 68-year-old female who presented with severe neck pain after a riding mower rollover. And this is the image we have here. Is there any of the residents who would like to chime in as to what we see here? Anybody?
Yeah, hey, Dr. Awuor, can you hear me?
Yes, I can hear you. Go ahead.
All right, yeah, so it looks like it's bilateral occipital
First of all,
condyle.
introduce yourself.
Sorry, I'm Alex Regino, one of the neurosurgery residents.
Okay, at Grant?
At Grant.
Yes, go ahead.
All right, so I'm looking at bilateral occipital condyle fractures. It looks like some spacing between occipital, that occipital condyle disruption as well, like ligamentous disruption.
Okay, so what's this spacing you're talking about? What exactly do you mean?
AO dissociation.
Okay, so there's this area right here, which is going to be important in the stability of this area. One of the things, this is called the, does anyone know what this space here is called? This interval? Alex, do you know what this interval is called?
Oh, is it the, yeah, C0, C1 interval? I've heard it in that paper.
Right, so we call this the Atlanto-Occipital interval, okay? And what is the accepted value? What should this be?
Less than 3.
Okay, typically less than 2 millimeters, okay? Less than 2 millimeters for the Atlanto-Occipital interval. And you can see this is probably more than 2 millimeters here, which it is more than 2 millimeters. And also you have an avulsion of the occipital condyle. So Alex, what would be your treatment of choice here?
Well, I mean, seeing as though it's an unstable fracture, I would, as it's avulsed, honestly, bilaterally avulsed with that AO disruption, an occipital to subaxial fusion.
Okay,
OC
so
fusion.
yeah, so this particular patient, this is what I would do on that patient. So typically with these, I won't go through the classification again, but this is the Atlanto-Occipital interval that we're talking about. This space right here, this should be less than 2 millimeters. So you should pay attention to that because it gives you a hint as to if there is some ligamentous injury. Now, just to review, occipital condyle fractures, 99% of these fractures you're going to treat with a cervical collar, okay? Very rarely do you ever have to perform surgery on occipital condyle fractures. We see a lot of occipital condyle fractures. 99% of these patients are treated with a cervical collar. You can consider a halo vest in patients who have bilateral occipital condyle fractures. I still put them in cervical collars. The only ones we typically treat with occipital cervical fusion, and rarely we also use, we do use a halo as well, but the patients that we usually take to surgery are going to be the patients with significant ligamentous injury or evidence of instability, meaning you have, you know, there's some type of distraction or translation in that area. Those patients are the ones that we would treat surgically. But again, only the patients with significant ligamentous injury, pay attention to that Atlanto-Occipital interval, and that should be less than 2 millimeters. The ones that we typically consider unstable in this region are patients who have an avulsion fracture. So avulsion fracture, significant ligamentous injury, evidence of instability, those are the patients we're going to treat with surgery. 99% of these patients we treat in a collar. All right, is Punit is Punit on?
Yes, sir, I'm on. Can you hear me?
Yes, so I want you to review this particular case for me. So here we have a 55-year-old female. We did discuss this last time, involved in a motor vehicle accident, who presents with severe neck pain. So in this particular image, what do you see and what's your treatment? What determines your treatment?
So this is a CT scan of the cranial-cervical junction showing sagittal, coronal, and axial planes. The most significant finding and the impressive is the axial. You can see a burst Jefferson fracture of C1 separating the right sided C1 lateral mass from the body itself. And you can see the movement of the C1 body itself away laterally towards the left from the lateral mass. It seems like a very unstable fracture and going to require most likely an occipital cervical fusion, sir.
Okay, so now if you did do an occipital cervical fusion, that is an option, but I'm going to say that I would not do an occipital cervical fusion in this patient. The reason why I wouldn't do an occipital cervical fusion in this patient is it's a unilateral ring fracture, okay? It's a unilateral ring fracture. With unilateral ring fractures, you can get away with a C1, C2 fusion. You preserve the patient's, you preserve a significant amount of mobility by just doing a C1, C2 fusion. Now, if you did have more than a unilateral ring fracture, then an occipital cervical fusion would be the best option. But with a unilateral ring fracture, even with with these patients with transverse ligament disruption, the best treatment is going to be a C1, C2 fixation. Okay. So my go-to is the Harms procedure, C1, C2 lateral mass fixation, and these patients typically will do well with just a C1, C2. Now, here's another scenario. Since Punit, go ahead. Since we have you for reviewing the Atlas fractures, go ahead. What would you, a 45-year-old male who's involved in the MVC, neurologically intact, how would you treat this one?
Yes, sir. No, definitely this is the 4-point burst fracture separating both lateral masses and anterior and posterior rings. This, like as you were just mentioning, this is bilateral ring fracture separating the structures. I'm not sure, looking at this axial CT of C-spine, that you can get away with the C1, C2. So I think for this one, occipital cervical fusion may be required or indicated rather than C1, C2.
Exactly. So so this is what I would recommend for that particular patient. So let's go over this. This is the classification of Atlas fractures. As you can see now, a type 1 is going to involve only one ring, either the anterior or the posterior ring. A type 2 is going to involve the anterior and posterior ring, and then type 3 is a comminution of the lateral mass. Which ones? Now, out of all these fractures, number one, what's the number one thing that determines whether a patient is surgical or not surgical for C1 fractures? It's going to be whether or not the transverse ligament is intact. Okay, if the transverse ligament is not intact, then those are the patients that we treat surgically. If the transverse ligament is intact, non-operative management, okay? So let's again, I can't emphasize that. So it's the transverse ligament. We're going to assess the transverse ligament with looking at an MRI, and there's also things that there are other hints to transverse ligament disruption on imaging. There's the Atlanto-dental interval that will give you a hint. That should be Punit. What should that be?
I'm sorry. Are you able to repeat the question, sir?
Atlanto-dental interval. How? What's the acceptable amount for that?
So in adults, less than 3 millimeters, sir.
Yes, so less than 3 millimeters. You want that Atlanto-dental interval to be less than 3 millimeters. That will be that's key. And then also we have the rule of Spence with the overhang, and you can actually see in our initial image over here. You had significant overhang on this side here, where you had the lateral, where you had the displacement of the lateral mass, and again, I can't emphasize how important it is to get with all these patients a CT angiogram to look at the vasculature, because the vertebral artery is actually looping around, sitting right here and going through the transverse foramen and sitting right on the posterior arch. So it's very important to understand if there's any injury to the vertebral artery, and also to look and see the course of that vertebral artery when you're doing the surgery. But also you look at this overhang here, that also gives you a hint as to whether or not you have transverse ligament disruption, and should not be more than 7 millimeters total. The Atlanto-dental interval should be less than 3 millimeters. In this particular patient, yes, occipital cervical fusion would be recommended. In review, let's look at this. As far as determining if something is surgical or non-surgical, like I said again, the integrity of the transverse ligament is the most important determinant, okay? If the transverse ligament is disrupted, cervical immobilization is an option, but typically the cervical immobilization is going to be preserved for these kinds of patients here that have a comminution of the lateral mass, because a lot of times when you have an avulsion fracture, when it's avulsed, once this heals in immobilization, you can still maintain, if you get good healing of that avulsed bone, you can maintain the stability and the integrity of the transverse ligament once that fracture heals, especially if it's an avulsion fracture. So those patients, you can get by with cervical immobilization. The other patients, I would recommend surgical fixation. Again, if it's a unilateral ring or anterior C1 arch fractures, you can get away with a C1, C2 fusion, okay? That would be the recommended treatment for that. Now, if you have multiple ring fractures, then you have significant instability to translate laterally, and those patients, you should cross C1 and go to the occiput. There's different options for C1, C2 fixation or fusion, and I won't go through that this time. We did discuss all these options last time. I'm not a big fan of wiring. I can't tell you the last time I actually wired a posterior arch. I don't think it provides enough stability, but I do use it to supplement once in a while, to supplement some complex fixations in this area, but not as my only surgical treatment, typically not. Now, one of the things I discussed last time as just a pearl, a take home with putting lateral mass screws is, now, when you're putting in lateral mass screws, you know, when you read about the techniques, there's all these different angles that you're given, and I mean, you know, in surgery, to me, I can't tell the difference between 25 and 20 degrees, really. So I keep it simple. We divide this lateral mass into 4. I do a kind of a modified Magel technique where I find the midpoint of the lateral mass, and then go 1 millimeter medial, 1 millimeter superiorly, and then I just aim for this outer corner. You aim for this outer corner, upper outer corner, and you'll get the perfect screw every time. You don't have to memorize any angles or anything like that. You'll just get the perfect screw every single time. All right, so we talked about neuronavigation being the best thing that ever happened to upper cervical spine surgery. I love this stuff. Neuronavigation, it has made really this kind of surgery very reproducible, very quick. We can do a C1, C2 fusion in 45 minutes or so, in and out. So it's become a really, it has really made this surgery super easy. Well, much easier than it used to be. Okay, I won't say any of these surgeries are easy, but it has made it much easier, much more reproducible than it ever was. So the positioning that I use really is I put the patients on a Jackson table with a Mayfield head holder. I typically just use a regular Mayfield. Even with the O-arm, with a regular Mayfield, you don't get that much scatter artifact. It's you still get a nice picture, and I use the radiolucent holder though. So this is the radiolucent holder, and then I just attach a regular Mayfield to this. The first thing we do once the patient is positioned is we get a lateral X-ray to make sure this is very important. I never skip this step. So once the patient is positioned, I want to make sure that I'm not displaced significantly. Okay, because if you don't get this lateral X-ray immediately after positioning and you continue to do the surgery, you could potentially, especially if you're not using any kind of neuromonitoring or anything like that, you can cause a significant injury to the spinal cord. So I make sure I get this lateral X-ray. I make sure I'm well reduced. There's nothing that's really pushing on the spinal cord, and the alignment is maintained. I either attach my stealth frame to the Mayfield or C2, then we do the exposure, we control the bleeding with bipolar and flow seal. Then we use the CMF screws, the small Synthes screws. I put one on the arch of C1, the posterior arch of C1, and then one on the C2 lamina, and we make sure that these are on opposite sides of each other, and then we do an O-arm spin. Now, what does that screw, what does that small screw do? The purpose of that small screw really is just to check instruments for accuracy. Now, if I'm going to C3, I don't put the screw on there because I quickly put my C3 screw prior to my C3 lateral mass screw, and then I use that to check my accuracy. But these will give you very precise points that you can check for accuracy prior to doing your surgery. I always make sure my navigation is very accurate before trying to do any of these surgeries. We then retract the C2 nerve root using a suction nerve root retractor, and then take a navigated drill, and I use a 3mm matchstick drill bit, and we just drill to a depth of about 6 millimeters into the lateral mass, and then but sometimes we may have to drill part of the posterior arch of C1 to really get a good angle into that lateral mass. And then every time I use a 3.5 by 34mm screw. The 34mm screw works for so far every patient that I've done this surgery on. Why a 34mm screw? It's long and it allows for you to have bicortical purchase. Okay, on almost any anatomy, you're going to have nice bicortical purchase with a 34mm screw, but at the same time, that 34mm screw length is going to sit proud enough to where you do have all your threads within the lateral mass. You don't have any threads pushing on the C2 nerve root. You don't have any threads irritating the C2 nerve root, and then it's sitting proud enough to where you can put your rod and line it up very nicely with C2. So that's what I use for every single case. We then just put our C2. We then place the C2 screws in a similar fashion. Put the rods in. Put the screw caps on. Do another O-arm spin, and then final tighten everything. And if a fusion is desired, we put which typically this is what we do. We'll arthrodesis the posterior arch of C1 and arthrodesis the C2 lamina, and then put some allograft bone over the arthrodesis areas. So here's another case. We have a 34-year-old male who was involved in an MVC. He was intubated at the scene. He had cardiac arrest at the scene and did undergo CPR. Right now, he's opening his eyes to command. He has 2 out of 5 bilateral upper and lower extremities. He's has a cervical collar in place. So what is the management of this patient? Are any of our OSU colleagues on? Anybody from OSU? How about Jason Milton? Is Jason Milton on?
Hey, what's up?
Hey, Jason. So what do you think is going on here?
Looks like AO dissociation. If they're in a collar, I'd take them out of the collar, sandbag them, and then they'll need a occipital cervical fusion.
All right. So that's I put that collar in. The collar is in place. I was hoping you'd pick that up. So perfect. Yes, you do not want to have these patients in a collar. Because that leads to actually a lot of times that's causing some more traction, and that can lead to further neurological injury. So what happened with this patient is there's a spot. Now you would want to get some additional studies, Jason. What do you want?
So I would get a CTA and an MRI.
Absolutely, because you want to know, do I need to decompress anything, right? You want to know if you need to decompress anything. You really want to study the ligamentous injury in this area. So the more information you have, the better. And especially in a patient week, you do definitely want to obtain those images. Now, the CTA, like I said before, all these occipital cervical junction injuries, you want to get a CT angio. You want to get some kind of vascular study because you really want to know what you're getting yourself into, and also know if there's injury to these to the vertebral arteries, because especially with this kind of distraction or dislocation injury, you can have significant vertebral artery injuries with this kind of trauma. And this is what Dr. Milton's describing as to what his surgery would be. Now, Atlanto-Occipital dislocations, there's multiple ways of looking at these and determining if you do have an Atlanto-Occipital dislocation. There's now what they're trying to do here is the Powers ratio. I want to try and erase this out of your mind. Powers ratio, I don't like it. I think it's terrible. It's not as accurate. So I don't even use that. I don't use the Powers ratio. But there are other more accurate ways of determining Atlanto-Occipital dislocations. It is an uncommon traumatic injury, and it's difficult to diagnose, and it can be missed a lot of times. Usually it's from a high-speed deceleration injury. Patients who survive, they can have impairment like lower cranial nerve neuropathies and unilateral or bilateral weakness. 20% have a normal neurological exam on presentation. So the Traynelis classification, pretty simple. You can see that well, this one here is normal. Type 1 is going to be where the basion is anterior. Here, you look here, the basion is more cephalad, and this here is called the basion dental interval. This length, this interval right here, this should be no more than 12 millimeters. No more than 12 millimeters. And we keep this simple because there's another, the Bayesian dental interval is going to be important for these type 2 injuries. That's where it's most important. When you're looking at the type 1 and the type 3 injuries, Bayesian axial interval is what you look at. So you have a line that's parallel, just lining up with a posterior margin here of C2, and the length in millimeters from the Bayesian to where that line is, that's going to be your Bayesian axial interval. Now we keep it simple. Each one of those numbers should be less than 12. If any of those numbers is more than 12, then you have an Atlanto-Occipital dislocation. Okay, so this is a very very simple way of doing it. Instead of using like the Powers ratio, which is less reliable, so I would not recommend using the Powers ratio or all the other ratios and whatnot, lines that are out there. So again, the occipital cervical junction can be considered normal if both the Bayesian axial interval and the Bayesian dental interval are less than 12 millimeters. And there's the Bayesian dental interval. Forget the Powers ratio. Now, the type 1 dislocation is associated with transection of the neural axis than in type 3. So that's something you should keep in mind, that you usually have more significant injuries with that type 1. And now the type 2 may result in cervical spinal cord disruption, and then vertebral artery injury. So keep that in mind. Actually, all of them can result with those with spinal cord disruption and vertebral artery injury, but it's more common with this type 2. And then the type 3 is associated with fractures of the C1, and this may be actually be a cord sparing effect. There's a 10% incidence of transient or permanent neurological worsening with traction. And with traction, I'm considering placing a cervical collar as part of that as well. So do not put these patients in cervical collars, sandbag them, or put them in a halo right away. And a lot of times, we take these patients, keep them in a halo, and fixate them using we take the halo out in surgery, but we leave the halo ring. Obviously, we take the halo vest off, fix this injury, and then we sometimes put them back in a halo even after fixation. But this is these injuries are very dangerous, very, very unstable, and unfortunately, a lot of them have very bad outcomes. Because of their significant injuries at the time, with significant neurological deficits at the time of their injury. The most sensitive method for the diagnosis is measurement, again, of the basioaxial and Bayesian dental interval on CT, and craniocervical fusion with internal fixation is recommended as a treatment of choice. We did discuss this patient before. We have a 90-year-old independent male with a past medical history of prostate cancer, is sent to the hospital by his primary care doctor because of complaints of severe neck pain after a fall. Vadim, are you on? All right, so what do you have here? What do you recommend for treatment?
This is a 90-year-old male. I see what looks like a type 2 odontoid fracture. I don't see any displacement. Yeah, is he neurologically intact?
Neurologically intact, very independent, mows his own grass, likes to go dancing.
So I think I think he requires surgery. That's probably the best option for him. Your two approaches are either anterior or posterior. Anterior, you could do an odontoid screw or posterior C1-2.
Why do you say it requires surgery?
I think in a 90-year-old odontoid fracture, very low likelihood of healing.
Okay, how about if he's 80?
I'm not sure that changes that much at 80.
Okay. How about if he's 60?
Well, age doesn't matter, Dr. Awuor. For type
Okay.
2s, they don't heal that well because of the blood supply.
How about if he's 35? Same patient is 35 years old.
You can attempt a halo, but I wouldn't do a collar or anything.
All right, so the thing to remember with these, and now this one, yes, we did do an odontoid screw. So over the age of 55, that's the typical guideline. Over the age of 55, significant risk of non-union. Okay, so over the age of 55, we recommend surgical fixation, whether you're doing an odontoid screw. Now, if you're going to do an odontoid screw, Vadim, what you have to have, what would be a contraindication to doing an odontoid screw in this patient?
So you need to be able to place the odontoid screw. So you need the trajectory, which means if you have displacement of it, you're probably not going to be able to get the trajectory. If they have barrel chest, you're not going to be able to do it.
Okay.
And anatomic considerations of their neck.
Okay. Now let's say all that is fine. He's a skinny guy. You see that you'll be able to put the. He doesn't have a barrel chest. You should be able to be. It looks like you'll be able to get the screw in there. What else do you have to make sure before you put an odontoid screw?
You have to be able to visualize the dens.
Right. I mean. Well, usually your visualization of the dens, a lot of times you won't even know that until you get to the operating room, whether or not you have good visualization. But prior, as part of your workup, what has to be intact in order for you to do this?
Oh, like transverse, the TL?
Exactly. So if your transverse ligament is not intact, then an odontoid screw is not an option. Okay, so the transverse ligament has to be intact. If the transverse ligament is not intact, let's say in this patient you did not have an intact transverse ligament, what then would be your option?
Then I think you're forced to do a C1-2.
Okay, great. So a C1-2, whether it's harms or transarticular, whether it's wiring. Again, I don't really like wiring, but those would be your options, right? So something to think about with these. Now, I've started. I do my odontoid screws now with Stealth, and the key here when using Stealth is that we use you put the patient in a Mayfield. So I put the patient supine in a Mayfield, attach the reference frame to the Mayfield. The O-arm just comes in and out. You keep the ring closed. That way it's easy to bring the O-arm in and out. And once you do your exposure, I put this CMF screw, this small screw here, right on C3 or C2. I just kind of look and see where the midline is, and I stick this screw somewhere. Okay. Then this little screw is going to be used as a reference point. That's all it serves for. You just make sure it's midline, close to midline, and obviously between your longest coli, and put that screw in there, and then you use that as your reference. Again, with navigation, your navigation is only as good as it's only as good as it is accurate, right? If your navigation is not accurate, then it's useless. And you should actually not use it. So in this particular patient, we in the odontoid screws that I use navigation, I make sure that I have a reference point. once we have especially compared to posterior surgery, this is a little bit more difficult to find a precise point where you can check for accuracy. Once you've done your O-arm spin, okay, then we check, make sure that our drill is accurate. So I first use a navigated drill and just drill just about 6 millimeters again into C2 and drill off the superior portion here of C3, and then I use a navigated hand drill and just navigate that through the fracture, and then we put the screw, go straight to the screw. I mean, compared to using the C-arm, I mean, this is really much quicker once you've done your O-arm spin and everything is aligned. It's usually a very quick surgery, as long as everything lines up. If your fracture lines up, this is definitely the way to go. So there's the patient post-operatively. These are our post-op images on that. The odontoid fractures, flexion is the most common mechanism, and a lot of these patients will present with neck pain. We did go over the Anderson D'Alonzo classification of odontoid fractures last time, so I'm going to go really quick over this. Now, what is the management of odontoid fractures? Okay, for type 2, if you have a type 2 fracture in anybody that's over the age of 50, the recommendation is surgery. Okay, there's a very high rate of non-union in these patients, so surgery for those patients. Okay, if you have a type 2A, type 2A is a type 2 but with comminution across the fracture. That's another indication for surgery. Then you have the type, then you have fractures that are displaced. Okay, whether it's type 2 and type 3 fractures that are displaced more than 5 millimeters. Okay, regardless of patient age, if you're displaced more than 5 millimeters, those patients will do much better with surgery. And then any progression of a fracture in external immobilization is also an indication for surgery. Now, the non-surgical ones, we typically treat those patients for 2.5 to 3 months with external immobilization. Then we take their collars off, we get upright x-rays. If everything looks good, so a lot of times we'll do flexion extension x-rays, and if that looks good, then we're likely out of the woods. We did talk about the surgical options for that last time, so I won't go over that again. So here we have an 80-year-old female with a history of mitral valve regurgitation, hypertension, GERD, who presents with severe neck pain and right upper extremity pain, weakness, tingling. She has 4 out of 5 strength in her right upper extremity. Otherwise, she's 5 out of 5. Do we have anybody from The Ohio State University on here today? I hear crickets. No one from Ohio State? All right, do we have anybody from anywhere who wants to take on this case and tell us what they would do? So I know it's probably, you know, the imaging is somewhat limited since you can't scroll through everything. So I'm gonna chime in here a little bit. You have a type 3 odontoid fracture, and you have a Hangman's fracture. That's what's going on here. A Hangman's fracture, type 3 odontoid fracture. And you have an MRI that's showing that. Anybody?
Hey, Dr. Awuor, maybe me and Alex can work through this.
All right, go ahead.
One sec. Yeah, we're just messing with sound here.
Okay.
Can you hear?
Okay, so yeah, so obviously the Hangman fracture looks like it's angled and displaced. odontoid fractures concerning. And there's obviously stenosis at the C1 posterior ring along the base there. So your goal would be both stabilization and decompression and reduction of the deformity.
Okay.
So to achieve that, you're obviously I would also get a vascular study, just given how much deformity there is. Was a CTA performed?
The CTA is done. CTA is good. There's no injury.
Okay, so
Do you want to go back to the CAT scan, or you're good with the MRI?
oh yes, I would like a CAT scan, but I think we had the CAT scan.
Can you repeat your last question, Dr. Awuor?
Oh no, I'm just saying, what's your plan?
Okay, yeah, I think that C1-2 instrumentation. So I would go posterior, do C1-2 instrumentation, do a C1 laminectomy, and then when you position the patient, obviously be very. I would actually consider monitoring on this, just for the positioning component, especially.
Okay.
And then depending how much reduction you got with positioning, see if you need to do a C1 laminectomy, and if you need to go up to occiput to get purchased there.
Okay, but your plan is for C1, C2.
Yes, if I can get the reduction by positioning the patient in the prone. It looks like it's highly mobile.
Okay.
But
Okay.
I would be ready. I would consent right away for occiput to 4, with laminectomies and at C1. Can you go back to the MRI? Just make sure I don't need anything more than that.
Sure. You do
at least the C1 laminectomy.
Okay. So what I'll tell you is that this is up here is C1, okay? This is where the C1 posterior, this is where the posterior arch is, okay?
Yeah.
You see that? The stenosis, you don't have any significant stenosis at C1. Right here, you don't have too much stenosis. Okay, you do have a bone fragment here, and you can see that over here. You see that? Right
yeah,
there?
I missed that. Okay.
And I'll bring that back here. So you see this bone fragment right here?
Yes.
And that's it right there. Okay. So a C1 laminectomy is not going to help you. It would be really of no benefit. So let's try again. Let's let me go to your chief, Jason. What do you think about stopping at C2?
I think I would go bigger than that. On your MRI, you had disruption posteriorly at more than just C1-2. So I think I would go bigger than that.
Okay. Well, there's another problem that makes it so stopping at C2 is a no-no. What is that? Because you have a type 3 odontoid that's angulated too, right? So what's the C2 fixation going to do for you? You know, you still have a fracture that's across the whole C2 vertebral body. This is not a typical Hangman's, right? You have a type 3 odontoid and a Hangman's. But yeah, I mean, you could potentially argue that you would do a C1-2 and then put the patient in a halo or collar or something like that. But I would want to go bigger. I would want to go bigger on this one. Okay, because you have significant really, you do have the angulation here, and you have the Hangman's on top of that. Jason, are you doing anything about this? Are you doing anything about this?
Can you go back to the MRI so we can see where it was?
Right here.
Yeah.
And here it is right here.
Yeah, I mean, I think you can try to get around the cord to get after it, but your issue is going to be your nerve root there, you could, I mean, you're going to have to remove a decent amount of bone there to try and get around it.
Yeah.
But I mean, I think you could certainly try.
Are
to
you
remove bone and do a rhizotomy and go after it?
okay? So are you going to go after it? Are you going to try and go after it?
If the patient does not have a deficit,
They do.
and my monitoring, they do have a deficit.
Here's the exam.
I got you. Oh yeah, and he's on the right too. Yeah, I would probably take a shot to see. I would have navigation to see once I had things reduced, how easy it would be to get to it. And if it was accessible, I would try to go after it.
Okay. Now, I'll tell you what I did, but here is, I did not go after it. Okay. I had a discussion with her. I said, you know, me trying to go after that small piece of bone is going to cause you more harm than good. So knowing when you're going to cause more harm than good is very important. And this is one of those situations. First of all, if you look at that piece of bone, what do you think the blood supply to that little piece of bone is?
It's non-existent at this point.
Non-existent. What's going to happen to it over time?
It'll just absorb.
Yeah. So I did not go after it. Okay. So what we end up doing was this. Okay, and over time, her arm strength improved. She's 5 out of 5 now, and completely intact, no issues. That piece of bone, I actually don't have an MRI or CT scan this far out, but I believe that piece of bone has resorbed by now, and I did not decompress that area. I did not try to do anything too crazy. I just fixated her in place. No laminectomy, nothing. She's 5 out of 5. She's doing great, no issues. She did have some delayed wound healing, but other than that, I mean, now she's doing great. So let's go over this Levine. Let's quickly go over this modified Effendi classification. With Hangman's fractures, type 1 is just a parallel vertical pars fractures. Type 1A, these are non-parallel fractures. Okay, so there's displacement typically with these 1A. The ones that we're going to treat surgically are going to be 2 and above. Okay, so once you start having a type 2 is going to have disruption of the 2-3 disc space. Okay, and then type 2A, you start having angulation of C2, and then type 3. The facets are sublux. There's injury to the C2-3 facet joint. So here I don't have the 2A. I don't have the 1A. The 1A, these fracture lines are not parallel, and a lot of people, kind of get worked up about when there's displacement in this area. As long as your disc is intact, a 1A, you don't need to operate on 1As. If your disc is intact, you typically don't have to operate. Even, I mean, a lot of these patients will heal very well over time. Even if they have significant gapping, if there's significant displacement of the pars, they still do well as long as this disc is intact, the facet capsule is intact over here, they do well. So I don't get too worked up about non-union of the pars. You keep them immobilized, you'll get a fibrous union. A lot of these patients, you'll flexion extend them after some time and they'll do fine. Now, the reason why our patient was really unstable, I know that was not it wasn't just a Hangman's, we had a type 3 odontoid, but when you combine this type of injury, this is we had a modified type 2 where we have a significant pars fracture, but then instead of the disc disrupted, we have the body disrupted. So you treat it the same as a type 2, and anything over a type 2, you're going to treat with surgery. That's typically the recommended treatment for anything over a type 2. Now, what are the treatment options for Hangman's fractures? You can do, especially with disc disruption, this will preserve some mobility. You can do C2-3 ACDF, it preserves motion. You can do a C1 to 3 posterior instrumentation. Now, if the facet joints and the C2-3 disc are intact, just a C1-2 fusion usually will suffice. So in summary, I know our time is running out here. I'm just going to wrap up here real quick. Occipital condyle fractures, treat most of them with cervical collars. The few that do have significant instability, or those patients we will treat, especially those with an avulsed fracture, we'll treat those in a halo or occipital cervical fusion. Treatment of atlas fractures, remember the integrity of the transverse ligament is the most important determinant of stability. Okay, if your transverse ligament is intact, we treat these patients with cervical immobilization. If the transverse ligament is disrupted, you can treat them with cervical immobilization, but I usually preserve the cervical immobilization for avulsion fractures because that bone can heal. Where the transverse ligament is, you have an avulsed lateral mass. You can actually heal that bone, and then the transverse ligament maintains its stabilizing capabilities. If you have a unilateral ring or an anterior C1 fracture in a patient who has a transverse ligament disruption, C1, C2 fusion is the treatment of choice. If you have multiple ring fractures, an occipital cervical fusion. For odontoid fractures, remember if it's a type 2 and even if it's not displaced, the patient's older than 50, they typically do not do well with non-surgical management. I typically recommend surgery. Obviously, whether you go anterior or posterior is going to depend on the integrity of your transverse ligament. The type 2A, those are surgical. There's a comminution across the fracture. Those patients, we do recommend surgical intervention. Then for the type 2 and type 3, if they're displaced more than 5 millimeters, then we treat that with surgery, as well as patients who progress with external immobilization. For Atlanto-Occipital dislocation, remember the Bayesian axial interval and the Bayesian dental interval, those should be less than 12 millimeters. If it's more than that, then you really need to be cognizant that these patients probably have a dislocation in this area, and cranial cervical fusion is the recommended treatment of choice. Here we have a 35-year-old who is in an MVC. Alex, what's this Hangman's fracture? What's the classification?
So that looks like it is displaced and angulated. So that would be just a type 2 Hangman's fracture.
Actually, the angulation, it's not really angulated. If you look at, even on upright x-rays, now you don't have all your information, but even on x-rays,
okay,
this was not angulated. So you have non-parallel.
So that's 1A.
fractures. That's a 1A. This is the one that a lot of people get excited and worked up about. They heal fine. You get an MRI, the disc is not disrupted. You can treat that in a collar, okay? Now, several months out, you'll still probably see this displacement. You may not have a union across that, but as long as you're stable on upright x-rays, you do not have to treat that surgically. As long as it's not progressing and you don't have progressive instability with serial imaging, and the disc is nicely, you have a nice healthy disc there, these patients will heal fine in just the collar, okay? We're gonna stop there for today. Thank you everyone for joining us. Next time we'll probably pick up more on C1, C2 combined injuries.
Fantastic. Thank you so much, Dr. Awuor. Now we'd like to open up the conversation to any questions and comments anybody might have. I have a question, Dr. Awuor. I know we didn't really talk too much about instrumenting C2, but my question is, what goes through your mind when you're deciding to do pedicle screws, par screws, or translaminar screws?
I don't do translaminar screws that often, but you really have to be, you should have that as an option. You should have it as something that you're able to do, just because you never know what you're going to get into with these kinds of these kinds of injuries, and you need to have a backup plan. The key to determining what you're going to do at C2 is, first of all, the course of your vertebral artery. And I typically just want the longest, safest screw that I can put in. So it really doesn't matter. What is the longest, safest screw that I can put in that's going to give me the most stability? And if I can do it safely, then that's my go-to.
Thank you. Anybody else have any questions?
All right. Well, thanks everyone. And I appreciate you taking the time to join us for this session.
Thank you, Dr. Awuor.
Thanks, Dr. Awuor.
Thank you.